the recording now, and I'll also just do it with the backup on my phone. So, okay. And then we can go through the consent process, which I sent you the script beforehand. I don't know if you had a chance to read through it, but I'll go through it here.
Yeah, I looked at it.
And so I guess first for the record, will you state your name and affiliation?
Thomas Kirschman, PhD, New York University.
Thank you. And so you are invited to participate in a research study about disaster research perspectives on COVID-19, led by Liesl Ritchie. The protocols for the study have been approved by the Institutional Review Board at Oklahoma State University as well as at the University of Kansas. Your participation is completely voluntary and there's no penalty to refusal, and you can opt out and withdraw your consent at any time without any penalty. If you agree to participate in the study, we ask that you participate in this approximately 60-minute interview, and then we ask that you participate in one subsequent interview over the next 12 months to follow up on some of your initial comments. There's no compensation for this study, and unless you request otherwise, the information you give will not be anonymous. So that means your comments will be attributed to you, but we believe this participation involves risks similar to a researcher's daily activities. So Todd, do you agree to participate in the interview?
Yes.
Thank you. Okay. So then to start, would you please tell me about your professional background?
My PhD I got in 2008 from the University of Pittsburgh. It's in clinical and health psychology, which is the application of the principles of psychology to the study of health behavior. My work has been fairly methodologic, having to do with what we call ecological momentary assessment, and now geographically explicit ecological momentary assessment, using mobile devices to study behavior and experiences in the real world where they occur. My work has focused mostly on tobacco control, but through collaborations, I've had the chance to study a range of different health behaviors and behavior change outcomes primarily.
And so when did you get involved with research on disasters?
So my work intersects with research on disasters in a couple of different ways. I mean, just trying to be concise, the second one of that couple would just be more recent. The fact that the COVID situation, although it's still unfolding and we don't know what exactly is going on, clearly is highlighting this intersection, not just between disparate impact of COVID on underserved populations, but a perfect storm of COVID and lung-related, tobacco use-related diseases, morbidity, mortality. And so my work, the first way it's connected is that my work I mentioned started with an ecological momentary approach, which when I was doing my dissertation basically meant Palm Pilots and really big pharma type research where we were interested in, for instance, who benefits from the drug itself versus the idea of the drug, using in my dissertation nicotine replacement patches versus randomized versus placebo patches. So it was in the years not far after that that I sort of realized that one way to reduce burden, to be honest with you, initially, I didn't initially see, like I was interested to hear your connections to sociology and all that. It seems like a lot of these things are coming together, but at whatever point, I saw this opportunity, we didn't have to ask people, where are you? But, we could reduce burden based on just freely available data through, OpenGIS resources. But then we quickly realized that, of course, the limitations of those things, and it's been a number of years now, I sort of became aware of the OpenStreetMap organization and the just really amazing, I think, underappreciated international disaster response, open source disaster response community out there. Anyway, so we tried to apply this locally. We focused a lot on tobacco control. So I got published a number of papers where we've tried to really operationalize and systematically gather data about the distribution of tobacco products across urban spaces and trying to do research to understand how regulations might impact that. Now, in public health, we view a vector, a distribution industry, corporate distribution vector for tobacco products, from a theoretical point of view, similar to the way we would think of a mosquito vector delivering a malaria agent. So, I teach a class on theory, but I often revert back to a HAV, sort of host agent vector environment model. And to me, it's clear, we're already developing a grant to look at, for instance, smoke-free exposure in public housing across New York City before the pandemic hit. And what we were proposing was that instead of just assuming the nature of the problem was that smokers can't quit and we should give them the quit line number, what we were proposing, our hypothesis, was that we could model smoke-free exposure in public housing as a function of the vector, the tobacco vector environment surrounding each public housing unit. So we were already thinking about how do you operationalize the vector environment surrounding public housing, and that could be in terms of both exposure, access to resources, and how does that affect individuals? And we think a lot qualitatively. So part of what I have a master's student working on now are questions along the lines of, in the context of that precision GIS, what's the human experience? So we're very interested in sort of clarifying what's happening in 2 dimensions by asking people open-ended questions like, what's it like to be a smoker in public housing, right? What's it like to be a smoker during COVID? Anyway, that's the work we had funded through the RAPID mechanism through NSF connects to my work. But I can talk more specifically about that, right? I'm trying to, I guess I'll stop, this is the stuff I could talk all day about, but hopefully that gives you a flavor. So I founded a youth mapper. So there's USAID and Patricia Salas at Texas Tech founded like 7 years ago, an international student mapping consortium called Youth Mappers. My chapter was one of the founding chapters at NYU. These students will do things like mapathons, collaborated with groups on the ground in developing nations. Whether there's a disaster or not, just it depends on the situation. And so maybe there's a disease on the ground and there's an issue around access to villages. How you can imagine all the applications. You can also imagine how that can be used in, first world countries, in sort of a more local area way. So it's weird that sort of through these technologies, I've been fairly connected to the disaster relief world, but I wouldn't describe myself as a disaster scientist. The way my colleague David Abramson would, who is a disaster scientist here in the School of Global Public Health. So anyway, my work is funded through the National Institute of Health. I've been aware of and have colleagues, and I've published in some ACM journals in the past, but it's always been tangential. But when Dr. Lafer reached out to me about the RAPID opportunity, we knew each other through the NYU Center for Urban Science and Progress, CUSP, where we're both affiliated. And she described and explained to me that NSF had this mechanism which is really focused on what they call perishable data, right? So recognize that this is a unique event and we can't spend a year going through a funding process. And so I could talk about that too, but that's sort of the connection. It's been interesting in the sense that when I talk about the HAV model and this sort of stuff, it's new to Deborah, right? Or to Dr. Lafer. But then that's the nature of I've done a lot of collaboration, but it's a different matter when you're collaborating with somebody who you don't already have some sort of shared platform. I think we have certain shared goals, but we don't speak the same language. Like the papers we publish have different types of method sections and things like that. That's also things that could be discussed. I don't know. Yeah, what your primary interests are. So let me stop, but hopefully, Does that answer your question?
I think it does answer my question. And so to answer some of your questions through that is that I've got maybe 1 or 2 questions that I'll ask about, your research prior to the COVID-19 project, but then probably, half these questions or more are about that rapid COVID-19 project. So we'll dive into both of those, and certainly part of it is about the methods and the collaboration piece. So I think, hearing your perspective on those will be perfect, and we should hit them as well. I do have a probe to ask you if you specialize in any certain type of disaster research, and it sounds like maybe spatial, behavioral, public health at that intersection.
So my work is funded by the National Institute on Drug Abuse, the National Cancer Institute, the Office of Behavioral and Social Science Research, and so we would refer to these behaviors as drug use and abuse or drug misuse type of outcomes, preventable health behavior research. And so, define disaster. Some people say there's an opioid epidemic, if you will, so, there's been acknowledgement, like for instance, the National Cancer Institute has formally published some pieces sort of, making it clear that they view the sort of the epi type of thinking, what I suggested earlier, somewhat playfully, the idea that it's useful in the world of urban drug use research to think about vectors the way epidemiologists think about mosquitoes. And there is a consensus growing around that, as evidenced by some published stuff coming out of NCI. So it's an interesting sort of thing. In a way, it's like we're sort of wannabe disaster. It's not really disaster research. But as you know, everything sort of seems to be merging in some ways. So absolutely. I don't know if it's disaster research or not.
Yeah. I hear what you're saying, and Converge is housed in the Natural Hazards Center, and so I will say that I think our underlying thinking was kind of stemming from that angle, but I think we can throw out that definition of disaster. I don't think it has to
that's good.
Remain here at all. Yeah.
It's good to be cognizant of the bright lines. I don't know if it's come up, but I've talked to David Abramson about this, and when I've read his stuff, one thing I've really appreciated, and it's almost like the psychology of the fact that, formal disaster science seems to refer typically to these acts of God and so forth. One thing I've noticed in reading it is that it has a more positive spin to it. Maybe it's because it's not as political, but when you read disaster science, there's a lot more focus on things like resilience. And it's sort of, when I read that, and then I go back to work on, urban drug use factors like Kenzie Preston has done in Baltimore, not commenting on her at all, but, just the way we think about it is more about how the negative consequences, right? How much worse things are going to be in terms of the impact on these people and their outcomes. And we don't talk about how can we build their resilience the way disaster scientists do, and it's just been interesting to go back and forth. But I'm probably wasting time for your interview, but.
well, I'm being bad here too, because I think that's so fat, because I shouldn't be interjecting, but it's really fascinating because I was originally, like I said, trained in civil engineering, where we're very, here's our box and we fit it, and here's our equation and we apply it. And so then when I transitioned to learning and reading the sociology literature, it was much darker, much more negative. So to hear that there's this other body of literature that I haven't studied that's so much more negative, and you view this as positive. But I hear what you're saying and agree with you that ultimately there is that positive spin of we think that we can improve it. We think that resilience is something achievable or that we can chase, or, so I definitely hear what you're saying, but that's interesting.
And we can learn from that. Why not? I don't see why we can't. It's not that we would just be completely Pollyannish about, the problem of urban drug use. Why not at least bring in the resilience perspective?
So then I think from your perspective, your definition of disaster, is there one seminal disaster event that has shaped your thinking about disaster research?
Well, I mean, honestly, just based on my training and what I do, the best answer to that is the ongoing tobacco use disaster, which still leads to the death of hundreds of thousands of Americans every year. And actually, these corporations are following the same playbook internationally, and we're going to see greater numbers even than we've seen in the past. And in a lot of ways, I don't see what's going to stop that. But, this COVID thing has opened my eyes too, and it's not, I think, to opportunities to collaborate, because I've been aware of the disaster science world, but I think there really are opportunities to help each other here, because again, this intersection between the pandemic and socioeconomic factors is undeniable, as is the link between socioeconomic factors and smoking, drinking, and the things that kill most people. Most people die from preventable health behaviors.
So you've talked about your research on tobacco. So the question is, what was the focus of your research before COVID-19? I think that's tobacco, but were you engaged in a particular study prior to, say, March of 2020?
Yeah, so I have a couple of sort of sunsetting R01 grants from the National Institute on Drug Abuse, co-funded actually by a couple of institutes, NCI, OBSSR. I can give you the numbers, and the specific information. But those are focused and building on some of the earlier work I was referring to, linking tobacco use behaviors in real time to build context in the environment. So we have a study ongoing now. You can check out the study's enrollment and recruitment site actually at the URL www.mapmob.com. It's an engagement site for what's called the NYU Neighborhoods and Health Study. And we've already been engaging with people there about what the implications of their address are for their health. The city, everything we do is about how can we help the city make better decisions. The city has tried in the past to make decisions about food deserts, for instance, but that's completely based on how they define a food desert. Typically what they do is they assume all you need to know about an individual is their address. And all you need to do is count the number of supermarkets inside the little box that the city uses for administrative purposes. And it's been shown now repeatedly that it doesn't work to change people's dietary patterns and improve well-being in cities. And our hypothesis is that we are focused more on anchoring effects than on address-based exposure effects. So what I mean is, we don't think of things as like a fishbowl where wherever your address happens to fall, that's the food you eat. People have preferences. Our hypothesis is that the implications of your address for your diet are not based on what's in your zip code. They're based on what are your food preferences and how long does it take you each day to seek out the things that you'd like, right? The way I think disparities are pervasive and hard to see in part because the implications of living in East Brooklyn, right, are not just what's in East Brooklyn. They're how long do people in East Brooklyn have to spend and how does that accumulate? Accessing food, accessing healthcare, accessing, moving people and their family around versus people in more dense, affluent parts of the city. So you can see how it's those sort of day-to-day routine dynamics that build up and could drive disparities in a way that, frankly, would be very hard to change, right, without just completely morphing the way cities work. But still, we have to try to understand what we're looking at, or we're going to pursue failed policies like we've so far been doing with food deserts. So, sorry, what was the question though?
I think you got that question. Okay. It was, what was the focus of your research before COVID-19, and were you engaged in a particular study?
We have this neighborhoods and health study, exactly. Yeah. And so we're already thinking about implications and access and exposure issues, we're already thinking, for instance, applying that sort of model. The next step was that, if you look at that website, is to apply that same type of thinking specifically within a public housing sampling frame, right? So instead of just recruiting generally, trying to use methods like that to understand what smokers, for instance, experiences are in public housing. If they can't quit, we don't want them to smoke inside. Well, what are their options outside? Just little stuff like that. It definitely has a sociologic, pretty soft angle to it. That's not the only implication of it. So then we were in the field, and what was interesting too is that because of that website we spent a lot of time and money on, it allows us to engage, pay, consent. So while many people had to leave the field, we actually been recruiting aggressively through the entire, we haven't been able to look at the data yet, but we are collecting information about where people draw a boundary of where they perceive their neighborhood to be, and they answer questions about their access to groceries and how safe they feel. And we've been continuing to collect that data over the spring and summer. And so now, we were going to do this smoke-free public housing stuff, but now I'm sort of regrouping and asking myself, basically there's so many opportunities now. What do we want to propose in terms of using that preliminary data to do something more? And one of the things we're looking at is whether we continue to go back to NSF or whether we try to do something at NIH. You know how it is, so it's hard to get funded.
It is. So because of the website, you've been able to keep your data collection going. Has the study been impacted or disrupted because of COVID-19 otherwise?
Well, sure. Sure. Everyone in the world has, right? I think every study running at this point is going to have an asterisk, like in general, because technically, and maybe ask me if we have to publish all of this particular section. I think everybody knows this stuff. I serve on study section for NIH. I think I understand this stuff. You're not supposed to change the stated aims of any proposal. Technically,
right.
They should be reverting the funding of everything because nobody's able to pursue their original aims because everything is interfered by COVID. I would argue that the fact that our aims were so related to the factors that are still in play here, that as long as we're willing to tolerate that pre-existing rule, that actually there's a big opportunity here to actually look at the ABA changes. We don't have a ton. We have one item we've been asking, for instance. We have a couple, 2 or 3. We try to minimize what we ask. A few questions about food patterns, and while we don't see, it's what I think we would have expected. While we don't see, we're not hearing people on these surveys anyway report, starving or just an absolute lack of access. There's this clear shift in terms of access to what we call preferred or specialty items, right? So we had to be artful about the way we referred to that, but of course, that would refer to many sort of culturally or just sort of traditional sort of food preferences that people might have, and you could imagine how that might play out differentially across the city when you combine it with the pause retail opening restrictions. There's a Chinese woman who works in my lab. Her home store is closed. So there's so many dynamics in play here. But just like with food deserts, I don't think it's enough to just say, well, people are either starving or they're not, right? That's where the psychology piece comes in. What are people's preferences? What would they like to do?
So what now then, shifting to the rapid, I guess, what is the focus of your COVID-19 research?
So we're approaching it theoretically from the have perspective that I was describing before. And so Sorry, I'm just.
You're fine.
Okay, so what's the question that everybody wants to know? When can we open up, right? When are we going to be free from all of this? The thing that's happening in terms of public health policy in New York City is the pause order, very similar to others, not that complicated, right? The premise is that if we shut down the physical spaces, right? It's not just restaurants. If we shut down places with doorknobs and handles, basically vector transmission surfaces, whatever you want to call them, museums, libraries. The premise is that we can reduce physical contact as a mitigation approach, right? It's not containment, right? We're way past that. So anyway, the thing about public health policies is that they're blind to ecologic context themselves, right? They are uniform, and they're laid down over highly dynamic areas, and so it's nobody's fault. It's not the policy's fault. It's not a criticism to say that they are inherently applied differentially across social and public spaces. We know that, right? So if we ask the question, one thing we can do is lay these policies down, sit and wait, and look at our indicators of choice. Another approach is to ask, why does this policy work or not work? Make a hypothesis and ask ourselves if we can measure anything related to it, right? If we can't, we can philosophize, but the question is, can we measure it? And so the rapid mechanism is meant for collection of perishable data that is very useful for this scientific problem, and if we don't collect it like now, we're not going to collect it. So thanks to Dr. Lafer, we got the first one, I think, at NYU. We were right out of the gates. And the goal was to develop a sampling frame where we would try to bound the problem. I talked about how in the past we thought about public housing, we thought about tobacco in schools. What we did was we chose a catchment of healthcare centers across the city. And we had a couple of different data collection goals. One of them was to collect perishable data about the rapidly evolving vector environment, three-dimensional epidemiologic vector environment, using a whole range of technologies. Dr. Deborah Leifer was in National Geographic, I think, last year for her use of these LiDAR cameras, which can be used in urban spaces to measure every handrail and bit, right? I brought in, and our team collected using open source tools and a tool connected to OSM called Mapillary, Facebook just brought actually. We set up a process where we could collect our own street view images and canvas the areas around the medical center that we've chosen. And this is a separate thing I can describe, but we use that using the principles and the methods developed through the disaster response community to populate what's called a task manager. For this one, we use Map Relay, HOT, Humanitarian OpenStreetMap. HOT is the most commonly used one, but it's not the only task manager. Well, we have a site on Map Relay where members of our team or anybody else can go in and view the data that we've added to the map along with others to OpenStreetMap, and they can add COVID-relating codes to that. So, you know, whether or not it's new restaurant tables on the street, or it's outdoor temporary containers and things around hospitals. There's a lot of need for perishable sort of built vector environment type of data. So in addition to that, is in a lot of ways a qualitative exercise where the team would pick a vantage point and observe behavior directly. So for instance, imagine observing the exit from one of these healthcare centers. What we weren't doing here, there's a lot of people that are focusing on sort of the absolute quantitative flow of people. Is it up? Is it down? What sort of modes of transportation? this isn't even trying to be that. I say it's qualitative because it's anecdotal, just to be clear, right? Like there's elements of what we're doing that might be useful for a quantitative model and elements that are more qualitative. So what our team was doing, in addition to collecting the objective data, was observing the decisions that people were making. So for instance, are people by and large, are they jumping in cars? Are they jumping in rideshare type cars or what seem to be private cars? Are they moving to the subway? Are they wearing PPE? Are they, do they rip the mask off the second they leave? Do they go into do they open the bagel store handle wearing the glove they just walked out of the hospital with? And in some ways it seems like miscellanea and sundry. It's like, how can you possibly, but I mean, that's the thing about qualitative data sometimes. When you're going after a really complex problem, you bring people in for a focus group and you just talk because it's exploratory in its nature. You can't always intuit every aspect of a problem. And so basically we're trying to study, where does the rubber hit the road? Where does the policy hit the street, the 3D vector surface and social determinants of health service, which is, the New York City sidewalk and social environment. And so the idea is, if you can collect data like that repeatedly over time and longitudinally, and that's a bit of a new angle here, right? Because in the disaster response, although there is, you can think of hurricane trackers and so forth. When in the mapping world, it tends to be more about the map and the static state of the map. In the OSM world, the big conference every year is called the State of the Map. So I don't think it's controversial to say that, you're building a resource and you're improving on that static resource. We in the behavioral health behavior world, right, we tend to be thinking in terms of behavior change trials. So it's more natural for us to think about how do things change at a more micro-temporal level. And so the idea is, if we can actually measure the implementation of the pause policy, right, we can operationalize implementation. If you've heard of dissemination and differential implementation type science, our proposition is that we can operationalize the implementation of the pause policy by measuring systematically, for instance, the case of restaurant seating. I'm right above it, that's what I'm pointing. It's been fascinating to watch how the restaurants push, and some of them get shut down. It's the market at work in terms of how many tables they can get outside, how many people are willing to pack in, whether the ones with the plexiglass are doing better than the ones without. And so the thing is that if we collect that, we can then overlay it, right, theoretically, with the indicators that everybody's tracking anyway on admissions and vulnerability indexes. And so the idea is then, even if it's initially looking retrospectively, how can we optimize these policies, right? Of all the elements of implementation, was it the plexiglass? Was it the, what was it that we could observe and actually measure that was affected by directly related to the pause policy that we could measure on the ground? Is there anything there that correlated, right, with where, when we look in retrospect, unfortunately, because eventually we're going to get some more hotspots in New York City. It's quiet now, right? That's the whole point. If we're in the field now, as the restaurants keep pushing it, where's the first hotspot? Is it going to be in Brooklyn? Is it going to be in Flushing? Is it going to be down here? So that's the, now will those indicators be sensitive to the measures, right? We don't know. That's what makes it explosive, because we're developing the measures still. And so we haven't yet demonstrated that we can actually model the outcome indicators that everybody agrees are useful as a function of the measures that we're developing. So, the name of this, I think, is it's developing epidemiologic mechanisms in 3 dimensions to enhance response. Everybody needs an acronym. But it's definitely, it's a pilot study, it's an exploratory study in that regard. But that's the idea. We'd like to inform the policy.
Sounds
by measuring it.
Super important and relevant across the world of global significance, right? You've talked about vector environments. Are there any particular concepts or theories that are guiding this research, and are they adapted from your prior work?
Well, yeah, so the vector environment approach is pretty well established in the world of tobacco control. I published a paper based on retail store inspection data conceptualized as a vector, corporate vector in Washington, D.C. There was a question, should tobacco signs be banned on retailers within 1,000 feet of schools and parks? And it's like so many other things, you could try to track down the origin of the proposal, but it's hard to find. I think there's a couple of potential sources, basically they're like working groups from 1 million years ago. But I think it's safe to say that it was sort of an intuitive feeling proposal, not based on data. But what we realized that working with the DC Department of Health is that we could test it. We had their inspection data, and we had geographic information systems. We sent teams out, and we took photographs and systematically documented the signage at every single tobacco outlet in DC, whether they were licensed or not, right? Because the lists and all that, the data on where those things are is not good. And that led to other things that we ended up working on. But we were able to build a model that not only answered the question, is it one of these things, but because we could model each outlet's propensity to sell as a function of the network distance to all these factors, right? We could look at their relative leverage. So we could look at schools versus parks versus public housing. So I've worked with this vector model. That paper I just described, I'm embarrassed. Was it 2014 or something? I don't know when it was published, but so I've worked with that. What I teach a class on theory. I think what I would, if I was going to mention one other one that I think is really important, it would be in general sort of implementation science, and in particular, I would mention the CFIR work by Dom Schroeder et al. This is the what is it? The something model for implementation science research. It's a common model. I forget the C word that's used for the CFIR model, but it's there are other models that are informing that world. The thing I like about implementation science is it builds on the re-aim stuff developed by people who used to call this type of stuff pragmatic trials, pragmatic research trials. Russ Glasgow, sort of the academic father of the re-aim. And basically, it was considered controversial for many years, but now it's sort of more mainstream. For instance, it's okay if you're doing a smoking cessation trial to make your primary outcomes the fidelity of delivery of the treatment, right? To make the provider behavior the primary outcome, right? When you're working in large medical centers or whatever it is in complex systems, the question isn't just what's the behavioral outcome, it's of all the points in the chain, where could we make the biggest impact, right? And so if it's the fidelity of delivery. So anyway, what I like about the CFIR approach, re-aim approach, is not just that it's pragmatic though. I think it's really theoretically interesting because if you look at the, I don't know how, sorry if I'm lecturing, I don't know, but I know you're just sort of listening. But
learning too, it is interesting.
And I don't know if it's things you're aware of or not. Then we all live in our own silos. But what I like about it is that it can be very useful for integrating different theoretical perspectives. So, for instance, the CFIR talks generally about inner and outer factors, and it sort of lays out a framework. But for instance, in the example of a project focused on the delivery of intervention, right, one might very naturally incorporate the use of the theory of reasoned action to understand how the caseworkers or whoever it is understand what they're doing, essentially, right? And what's determining their behavior. So that there's a lot of opportunities for sort of hierarchical, multi-level use of theory, right? You can have a psychological, individual health behavior theory nested within the more general implementation framework, whose outright the tradition. If you look in the literature and you look up theory of reasoned action or theory of planned behavior, right? Everything is going to be focused on, you know, application to smoking cessation outcomes, application to dietary outcomes, application to this, right? It's like we're stuck in that mold. So that the CFIR allows you to say, hey, look, the focus of this is on this systemic problem, and we're not even looking at cessation outcomes, but we're still going to use the theory of reasoned action. You know, imagine that. So I mean, that's still for me. I mean, I'm teaching theory this fall, so a lot of it is sort of just philosophical.
Mm-hmm.
I haven't actually. I couldn't give you an example of what I just said using theory of reasoned action within CFIR myself. So I'm more speaking hypothetically.
Mm-hmm. I think it's fascinating, and I'm taking notes, and I'm trying to keep my brain focused on this instead of like, oh, how can I apply this in my own work, where I try to bring together all these other things. So I'm trying to keep my head focused. For your COVID-19 research, you know, the question is, what are the primary methods you're using in the project? You talked about LiDAR, you talked about the map relay, and collecting street view images that way. Can you talk more about the methods?
Yeah, I would say in general, it's field survey, cluster randomized field surveillance methods utilizing a range of modalities, primarily mobile phones in the hands of trained research staff. We were fortunate, we were so fast, we were able to bring on some students who were still in the city, and we had pretty strict requirements. A bunch of students, it was horrible, right? 50,000 students were just sent home, and everybody's internships were canceled, and people were in New York City from international place, you know, like it was just bad. So anyway, there was no lack of people looking to take part in research, but we had to be selective, obviously. So what we ended up doing was recruiting, I think it was 15 master's undergrads who were residents of New York City, were still in the city, could access our DETER sites, our cluster randomized focus sites, without using public transportation or anything other than walking. I mean, you know, maybe one of them, we didn't tell them they couldn't ride a bike. And so it used a range of modalities, right? So the phones were used both for some of the qualitative stuff. So for instance, use a GIS app where they could use anonymous things like arrow symbols to simply quickly annotate what they were seeing if they were watching people exiting a door or something like that. They also use, I mentioned, this platform called Mapillary. It's kind of like Capillary. Anybody can use to collect street view images. In fact, I mean, we set this thing up to be something that could scale. We were going to push out. We still might in New York City. Anybody could use it. I mean, it's live now. Just an aside, just the politics are so caustic that we're hesitant. But I mean, like, technically, what's cool about OpenStreetMap and Mapillary is that anybody can take this out and document. So if you're a nurse, and I'm not advocating, like it's like so many other people, I do not want to state a personal opinion about how people should. I mean, obviously, I wear a mask and all that. Don't get me wrong. It's just that let me say what you could do with this, right? If you're a nurse and you don't have an opinion, you're just a nurse, but because you understand that vector transmission is a thing, maybe as a hobby, you'd like to keep track of the roads directly surrounding your medical center in terms of sidewalk tables. Technically, any nurse in the country right now could take out Mapillary and directly stream images of those cafe situations that could then be, within a matter of minutes, added using COVID suffix tags to this sort of platform for basically, one person could allow us to do longitudinal modeling of the sort of restaurant table version of a vector environment, over time, and do really powerful things. We're not crowing that from the rooftops because, it doesn't, you'd be pretty, you really, who knows what would happen if people started going out, holding up cameras and doing this, right? I don't even, that's where I don't even want to go there, unfortunately. But, or fortunately. So anyway, yeah, I guess I'm just saying that out loud. We set up some of these modalities. They're still there. In fact, if you want to play around with it, I don't know if you, but I could send you follow-up. You could join our Mapillary project. You actually don't have to, but if you use the Mapillary app, you can, if you have an OSM account, you can log into a project and you can contribute. But whether you contribute to a project, your data would go to the same OpenStreetMap anyway. It would just be from an anonymous user. It wouldn't be part of our project, right? Just to be clear. But I mean, I'm probably just saying it because you and I are talking and I'm answering things open-ended. And like I mentioned earlier, I said, I feel like the open source, international open source or humanitarian response world is an underappreciated thing that's happening right now. I would put this there too. I mean, the fact that I say this to my students, right? Like people are looking for research projects. There is a tool where you and your friends can do this, right? You can do a mixed methods project where you can have precision GIS and you could do some interviews, and these things are off the shelf right now. And so, yes, a lot of this is controversial, right? But on the other hand, this is all anybody's talking about. It's the only thing on TV are these mass dust-ups. And just sort of saying, I mean, there are basic technologies that we can use building out of some of this field surveillance that would allow us to do science on this. Like we could stop just yelling at each other and actually, we could actually measure it.
Yeah, I mean, right, if you could incorporate citizen science, you could really scale up and understand how different cultures across the U.S. or even larger, further, even beyond, how that could impact, these policies, right?
It would be over in the first day because it would be called something else that it's not.
It would. Did you see that the high school kid from Georgia who posted those pictures? They got suspended. So yeah.
Yeah, but I heard. Yeah, I have a 12 and a 7-year-old, and they're asking us, do you want to? It's like, oh, I don't know if we do, but ask me what I think the odds are that we'll be open for more than 2 weeks. You know what I mean? My wife is a physician. She works at Maimonides in Brooklyn, and still has to go into the hospital. So, I mean, we're fortunate that basically I can homeschool our kids, but, it's not good for my academic career. Not that I'm complaining, of course, because we're very fortunate, but anyway, this is our national experience right now.
It is. You've applied these theories before that you're applying here. As far as the methods go, these different smartphone apps that you're referencing, OpenStreetMaps, all of that, have you used that before in previous studies? Yeah. And are you having to make any adjustments, to your reconnaissance work because of COVID-19?
Only in a positive, not really, because of the fact that it's such a natural extension from the way we've been already operationalizing the things that we would measure anyway. I mean, like I told you, we were already taking images of retail storefronts. So it's the same exact data collection just in that example. But I would say that it's been positive in the sense that, not for everybody, obviously, but I'm trying to think, do I sound like this is my personal opinion? I don't know. But if you just even look at the funding priorities, if you look at the priorities for biological and medical research at NIH and what public health research has gotten and continues to get, it's still broken, but at least there's a national conversation about what the heck public health even is. And I hope, and hopefully our work can help people realize, if we keep working hard, that there is real science here, and that actually we should be funding this more. And aside from the funding, it's been positive just in the sense that, look, there's been new sources of data that have been opening up. Some of the big proprietary internet players that normally you would have to beg them for data are now making new sources of data available, which is great, and it's to their credit. So if anything, it's been positive in terms of awareness and acceptance, and also actually sources of data and collaboration.
Let me interject for a second. I didn't mention this earlier, but you mentioned being maybe concerned that you were coming off with opinions or something. I will share the transcript from this interview with you, so if you want to review it and make sure you came off the way that you want to come off, you'll have that opportunity.
Okay.
So don't be overly concerned about that.
I don't want to, thank you, I appreciate that. And I don't want to sound too paranoid either, just, yeah, anyway.
What is the expected duration of your project? You've mentioned longitudinal.
Well, that's the theoretical, anytime you're doing a pilot study, there's sort of, I would say the purpose of it is to demonstrate the utility of the measures. Why? Because we think that if we have the measures, then we would be able to track things over time. As opposed to saying that with this snapshot, we've solved all the world's problems. But then in terms of the duration of the actual project, it's more of a snapshot, right, to capture this perishable data. Actually, we're drafting the initial paper, and I don't know exactly we're drafting it now. So we'll see exactly, what sort of outlet we end up, but it's RAPID itself, obviously getting this out. We're actually releasing the raw data, which is part of the RAPID mechanism as well. We already have it cleaned and ready to go. Again, that mostly kudos to Dr. Deborah Lafer there, who has really led a lot of that. But anyway, I would say 6 months, I think is the official. I can tell you, I can look it up so that we got it right. I think it's just a 6-month project. And we didn't even ask for all the money. They were up to 200,000. I think we got somewhere around 100. And we were right on the nose.
You've mentioned Dr. Lafer. Are you collaborating with anyone else on this project?
Not on this one, no.
And how did you get connected with Dr. Lafer then for this project? We
are both faculty at the Center for Urban Science and Progress at NYU. It's the CUSP is part of the Tandon School of Engineering. Dr. Lafer, her primary appointment is at CUSP, and she's a director of a program there. I've been associated faculty with CUSP for 5 years. Over the past 3 years, not this year, previous 2 years, I led capstone projects with teams of 5 CUSP master's students. So I've been, submitting grants with CUSP researchers, so we knew each other through that. And Deborah was aware of the RAPID mechanism, and so we joined forces through that. She just reached out to me basically and said, they're doing this thing. I don't know that much about public health. Could you help me, sort of frame it in terms of the theory? A lot of the stuff we're talking about today. And so that's how it came about.
So excuse me, we're right at an hour, which is fine for me, but I just want to be cognizant of your time. We have 3 more questions.
I can
That's okay.
That's fine.
Okay.
I don't have anything new, so that's
okay.
fine.
What do you anticipate to be or are the primary challenges with conducting your RAPID study?
Well, we're done with it now. I mean,
okay.
I mean, we have the data. We're writing the paper up. It went surprisingly well. I just say that because, you know, it's like every project as a rule tends to have problems. I mean, considering how rapid it was, sort of amazing. I mean, we spent the entire budget down. We collected all the data we set out to collect. Really the challenge is the translational one, I guess I would call it. Although, I mean, a lot of times people use translational to refer to sort of clinical translation. I'm referring it to more of sort of upstream, I suppose, basic science. But yeah, I mean, I think that we can talk about vectors and theory. The challenge is how to advocate for the science. I don't know how to say. I usually avoid the word advocate, but you know, I just the challenge is because the science. You know what? Here's an example that I remember from years back when the FDA was going to change CTP, Center for Tobacco Products. The FDA was going to start regulating e-cigarettes, and they came up with this whole idea of regulatory science. They call it tobacco regulatory science. And there's all this money went into that, and it was through that whereas before that tobacco control provided it, thought of itself as blindly objective science, although all scientists struggle with certain aspects of that. When the FDA stepped in, it was made explicit, this idea of regulatory science, this idea that you can't ignore, because there's a slippery slope there into politics, right? Like, and we're seeing that play out now, and I'll spare you that. But the decisions on which type of regulations to fund have huge implications. I told you my dissertation was in studying the nicotine patch. For me, it was just natural to think of e-cigs as a way to deliver nicotine to smokers. Mm-hmm. But there's no funding for that. And so that's another story. but if you do that, you're a bad person if you do that, because you're hurting kids. And I don't want to hurt kids. And so, but I do nicotine research. So, but anyway, not anymore. But that's the thing. And so here, to be perfectly honest, the biggest challenge is not the science. We've been preparing ourselves for this for a long time, and it's mostly positive, I think. The challenge is communicating the science. And before you even get to the talk show version of, I don't even mean like how to communicate to the public, because I can't even begin on that. I think the question I ask myself is, how do you convey it to policymakers? And yeah. So that's why I would begin and end, like with our work, I would begin and end with the PAWS regulation. It's not because I'm a policy analyst. It's because if anybody's going to agree that our work is worth anything, it's going to be based on our ability to add something to the knowledge base about why or how to implement these policies. Everything else is academic minutia, I think.
Much like everyone else, your day-to-day life is probably being affected by the pandemic. What are some of the changes to your personal life that are impacting your professional life or research?
The main thing is my kids. It's like way above anything else. I'm a professor. My wife's a physician. I'm home alone. And my 7-year-old is a diagnosed crazy person. I have to, let me clarify. He has the hyperreactive version of ADHD, and he cannot sit in front of the screen. Mm-hmm. So remote education for him is not a thing. I mean, he can sit with me and I can force him to look at the screen, right? But So anyway, basically everything's fine for my family. I can't complain because of the state of everybody else in the world. The thing that's taking the hit is the hours I can devote to my professional work is taking a huge hit. I don't know what I'm going to do this fall. Don't get me started, right? But I mean, I have to teach this fall in my youth students. And, you know, I already can't get my research done, and I now have 2 kids I have to homeschool. So, to be honest, I don't know what I'm going to do. So, you know, but I'm fortunate. I really am. I mean, in some ways, I would have never gotten this time with my 2 boys. It's so funny. You know, people ask you in life, would you go back and do it? Obviously, I would go back because all the people would be dead. So, you know, obviously, but just in the microcosm of my own struggles, I mean, it's like my mom said when we had kids, the highs are higher and the lows are lower. I mean, it has not been a bad thing that I've been able to spend so much time with my boys and got off the treadmill. But the question is, how's it affecting the professional side of things? It's really bad. And I'm worried about the state of academia. I mean, you know, NYU's got a lot of money, and there's certain places that are kind of okay, but just the whole premise, I'm worried about. You know, NYU's asking students to fly back here. We'll see how many come, but some tens of thousands are going to, and they're going to do what? They're going to sit in. Again, please don't quote me on this, but they're going to sit in dorm rooms and hotel rooms, taking virtual classes with a professor that's 3 blocks away in his apartment. I mean, what? It seems insane.
I haven't looked up what NYU is doing, but they're and KU is changing all the time, it seems like, but they're asking people to come back to still do remote instruction or online.
Well, and at a certain level, you understand, I mean, basically, I think it's a blatant reality that these universities are trying to stay alive. They're trying to not fire their faculty. And they're not saying that out loud, but that's the reality.
Mm-hmm.
But it's the choices that we're having to make as a society are just insane. They're insane. I mean, we're sitting here in Greenwich Village. We just got it under control. We live right next to, we live in an NYU building. And just the idea that literally, you know, from every reach of everywhere, we're going to have all these people coming in here. I mean, it's, and not to mention the new school and every other school in the city. It seems like a terrible idea. You know, it's one of those historically people are going to say, why did they do that? You know, but I mean, anyway.
Okay.
So, I mean, I know you know all this. We're just gossiping now, I guess. But,
I hear some drilling upstairs, so I'm going to ask for that to stop.
I can't hear it.
Okay, that's good.
I can't.
In what ways are you coping with all of this going on?
Like personally, I don't know. I think, I don't know. I'm the sort of person like people in our profession who's very sort of hypercritical and tries to feel good about myself by like doing good things, you know? And so I think my approach is like my wife and I both call it sort of survival mode. I mean, not that I'm, you know, I think I'm still reasonably, my well-being is reasonable. I don't think I'm in a clinical state.
Mm-hmm.
There's a sadness and a just dread, I think is the word, right? You know, fear of impending awfulness. And yeah, it's tough. You know, it's weird. It's surreal in the city too, because the whole concept, I don't know if you disagree or how much, if you've had the chance to go to New York City ever or whatever, but it is in a lot of ways, it's a different world. And you know, for people who haven't been here, it can be overwhelming just to walk down the street. And the reason to be here often is not the square footage, right? The whole idea is the location. You're getting access to the city. And so any New Yorker will tell you that. And so I think in some ways more so for people who know the city and have a relationship with it, have been here for long periods of time. It's very strange having so many things closed and so forth. So it's sort of, in a lot of ways, it's existentially challenging. You know, you think about where we've seen white flight, you know, back in the late 60s and all that with DC. Even just in my colleagues, a lot of people are reevaluating. You know, maybe I'm going to think about that suburbs thing again. I think we're still. You know what? I think the last thing I would say is, I think the best I can make sense of it is that it's still a transition. And, you know, like looking back on life, I'm 44, it seems like transitions are always the hardest part, but you can't really understand them until you're done with them. So I feel like we're still in the transition, and we don't know what it's going to look like on the other side. We don't even know when the transition is going to be over. And so it's kind of just a keep your head down thing. Mm-hmm. I think is kind of where I am psychologically. How can I possibly say I'm good or bad when I don't even know what's going to happen today or tomorrow? Mm-hmm. I don't know how I'm going to take care of my kids and whether they're going to be at school in 3 weeks. So, you know, I'll let you know. That maybe that's what the second interview can be for.
The last question is, to date, what have been the consequences, if any, of the Black Lives Matter demonstrations following the killing of George Floyd on you and on your research?
Well, it's been positive in the sense that I think it's highlighted what we in public health have always talked about. My research is funded by taxpayer money. You know, my job is to make society a better place, and NIH defined priority populations, the focus of all of our work, if it's drug use and abuse, or health behavior, or urban health, as the science of helping disparate communities, right? Mm-hmm. It's not just the industrial worried well who want to track their steps. So, you know, I think it's been interesting. I've seen it on faculty meetings be really positive too, because it's empowered factions of our faculty to push things even further, right? And so this is confidential, but, you know, I don't think it's something that's highly sensitive. We're actively now looking at something that would actually be called an anti-racism center at our School of Global Public Health. So I think it's so positive on so many levels. Mm-hmm. In terms of, our student body and so on and so forth. So, you know, in my theories class, we talk about intersectionality, and there's this debate, you know, some people want to model society, and they think of intersectionality. I mean, as I understand it, the idea is that it's not enough to just put gender and ethnicity in your regression model, because they're not, the confluence of those factors are more than their sort of additive, you know, regression beta value. It's actually more of an exponential qualitative difference. But nonetheless, there's this somewhat philosophical scientific debate about, okay, well, still, does intersectionality tell us that a priori we should focus our resources just on, you know, disparate communities? And what I challenge my class with is, I say, well, you know, the problem is that when you make a community into a petri dish and you only look at them, you can end up blaming them. This is like the sociology thing too, right? There must be something wrong with them, so we'll only look at them. And oh, look, it's this thing they're doing. But, you know, because the other case is you do need to look at all of society, because if the difference is, you know, this ethnic enclave is not doing as well as this one, then actually what we need to do is zoom out and try to lift them up instead of asking what are they doing wrong. And that's where that resilience thing I like. Because I was saying that earlier, right? Like that's the thing. Like in drug use, it's always like, why are they reacting to cues? They're more reactive to menthol cues right?
Mm-hmm.
It's their fault versus there's an industry that is distributing a deadly agent, and and we could look at it a different way. So, and the problem, we need to account for all of these things, but I think that that just like intersectional theory would tell us that it is ethical to say that Black lives matter in research. And it's not to say that they matter more than other racial ethnic groups, it's that they matter as much.
Mm-hmm.
And the problem is that they haven't mattered as much. And, I think that every single study that includes tobacco indicators should oversample African Americans because they're differentially impacted way more.
Mm-hmm.
That, it's like everything else. They smoke less and yet they die at a ridiculously higher rate of tobacco-related diseases. And so it's not enough to just say, oh yeah, we recruited white people, Latinos, and African American. I think that no, it's helping us move this debate further. That actually, we shouldn't not include Black people in research because I really want to focus on my idiosyncratic scientific method, and that would no, it probably needs to be more explicit.
Mm-hmm.
We're going to make ourselves irrelevant if we don't, because that's sort of the point, right? Like that, I think, and that's why it's healthy to hear from our faculty too, because I think that's what's shifting, right? It's not that everybody knows that I, as a smooth-talking white guy faculty member, can say things out of my mouth like, I appreciate this or that. Now it's more about like, what can you do? And I think that's good. So yeah, even on the faculty meeting where they were talking about anti-racism, I think it was raised by at least one person that, should we use tolerance? And some of the people advocating for the anti-racism thing jumped right on it right there. And when they said it, it was clear that it was the right answer.
Mm-hmm.
And I'm not sure if that would have happened that way,
mm-hmm.
right, without everything having been different. But now there's no question, like that's what they're going to call it, So I think it's good.
Yeah, that's great. I agree kind of, with the Black Lives Matter and it totally bringing out at a much broader level this idea of like what you're saying, not in isolation, but there's this supply chain that is feeding it, right? And it's not that they're doing anything wrong, it's the supply chain.
I had there's an African-American woman who applied to our doctoral program, and we've all had this, but man, she grew up in the city. I had her apply through our urban doctoral fellowship, and she would have gotten, it kind of goes conjoint with that thing. And she was in the final cut. And it's one of these where this is the saddest thing. I talked to somebody who was in the meeting after, and they said the worst thing I think they could have said. I didn't flip out when I heard it, but it was one of those. She said, you had to be in the room, right? And it's like, I can't even believe somebody would say that, but anyway, this woman didn't get the slot, and our doctoral class that year didn't have any. I don't think it had any non-white people in it. And the year before, it had been majority, but still, it's like I still don't know how that decision got made. And it obviously on first, like it kind of affected me. So I mean, I can't say it out loud. I'm saying it to you now, but. It's that sort of, I feel like that was an example I have in my own memory bank of where it can't just be theoretical. Because that's one of those where that makes all the difference. It's one thing to say it and then be like, oh yeah, but the number here says this and that, and we're going to make the other decision, Anyway, that woman probably should have been accepted to our program. She grew up in the city. She had she actually had worked at the Department of Health for like 10 years. So she had existing, like that's what I was saying to the program too. She had access to data. I said she could probably do it. How many students struggle with their dissertation because they don't have connections? If something falls through. I'm just complaining to you now, but I guess the context of it is that it's everywhere throughout, right? That it's not necessarily affirmative action, but there are enough cases where there's perfectly qualified people, and qualified should not just mean a tester, right? It should matter that this person is from the city, and that we have like no people. We have no African American women from New York City. Actually, that might not be true. It might not be no people, but it's very small, the number of people with those qualifications. And those qualifications should probably matter, right? So.
Yeah, I live in Kansas. I
use that, except I have some good friends who were new Manhattan, Kansas, and I went to a K-State game once in Manhattan. Is that Manhattan?
I'm in Lawrence. K is Lawrence, K-State is Manhattan.
Went to a K-State game. I met Kathleen Sebelius. And to this day, I still sometimes in talks and stuff, I use Manhattan, Kansas as my example. When I'm saying whether you're in rural or urban, I use that. I say if you're in Manhattan or, Manhattan, Kansas. Anyway, sorry, I talk too much.
No, but you're good.
Kansas is great. But they're different worlds.
It's very white. I'll say that.
What's the matter with Kansas, right? It has an interesting political. It's not as red as the rest, right? Is that right?
Like Lawrence is pretty blue, I think, but a lot of the rest of Kansas, and as I understand it, more Manhattan, is more kind of the Kansas City suburb Lawrence, so this east side of the state is maybe more blue, and we're still very east, and so as you get to Topeka and central and west Kansas, I think it gets pretty red.
It's interesting. I have some good colleagues in Oklahoma and North Texas. I don't know if Mike Busanel and them at University of Oklahoma, and they do disparities research. It's so interesting because it's so red there, and yet the disparities issues are so apparent, right? There's so many just people who are way worse off. Actually, New York City is good for your health. The poorest people in New York City live longer than the poorest people in the Rust Belt and Bible Belt. That's a known fact. And like I see through my colleagues in Oklahoma, the destitution that people are facing. It reminds me of that Iglesias book, I think. What's the matter? People voting against their economic best interests.
Right. With like access to healthcare, even in some of these really rural areas, but it's like they're directly voting against themselves having good access to healthcare.
And how fair? That could be really bad, right? That could be the difference between like a day's worth of travel or something, right? It's like
hours to get to an emergency room. Laughing to keep from crying. Sorry, I don't mean to laugh at these terrible topics.
No, I totally appreciate it. Anyway.
Well, thanks so much for your time. I appreciate it. Anything you want to follow up and share with me, immediately after or over the course of the next year, I'll be happy to hear from you and bring it in. So just let me know. Then I'll reach out within the next 12 months. Good luck with the fall.
Thanks. Good luck to you too. And it sounds like an interesting project. So I'm genuinely interested in what you guys come up with. It'll be interesting to hear.
I think we kind of all have a desire to almost interview ourselves as well too, to kind of document where we're at with the process. Just to give you I don't want to take up your time with my personal life, but I feel compelled to share since you've shared so much. I'm pregnant with our first child. And so like in Lawrence, we had almost no cases, and then the bars opened up, and within a matter of days, we were an order of magnitude higher in cases. And so a very clear trend of what the fall would look like when college students came back. And so it's like, not having to deal with the K through 12 situation and online learning personally in our house, but having that still overlay decisions that we make and managing professional expectations.
Doctor's appointments and everything, and I mean, nobody wants to go to the hospital right now, so I can only imagine it. Not probably not the pregnancy experience that you would have ideally chosen. Hopefully you're healthy. I mean, hopefully it's going smoothly so far. I mean, my wife's a pediatrician, and I'm well aware of all the, how crazy it can be.
Mm-hmm. So far so good, I would say, but there's, our own bumps in the road, but health-wise, doing okay.
That's good. That's
well,
great.
Thank you.
You got that pregnancy glow. I was wondering what that was. That's the pregnancy glow.
That's the weird lighting in here, actually. All right. Well, thanks, and again, good luck, and we'll talk in the future.
Okay. Sounds good.
Bye.
Bye.